So good evening everyone. This is Dr. Vineet Sehgal and welcome to our this very important session in the Advancements in Ophthalmology series. So this is my first session and I would be taking a session on a topic which is very close to my heart. So for last 7 years, when I started my glaucoma practice way back in 2014, when I was doing my fellowship, at that point of time, I seriously started the glaucoma management of my patients. So even when I was in RP Center doing my fellowship, I was wondering for the surgical results that we are having of our glaucoma patients, and I was also thinking that what is the domain which we are still lacking for our patients. I thought that why the patient has to put medications throughout the life, and even if he misses one medication, there can be a permanent damage which can decrease his visual acuity forever. Second thing, what I thought is that because the surgical results they are very unpredictable, can we have a thing which is non-invasive where the patient would not have a too much fear of losing the eyesight and which can basically be repeated. So in last 1.5 year I have got the answer, or I would say that I have got an option. It still is basically an emerging technology where which I would basically discuss today. That is a very important laser that we have got in the ophthalmology. This is called micropulse laser. Okay, so what is actually a micropulse laser and how it is basically working in glaucoma, I would basically discuss my experience with you and how to do this micropulse laser. So many of the residents, postgraduates, and even consultants are in this session. I welcome you all, humbly accept your gratitude towards me, and just an introduction about myself and this platform. I'm Dr. Vineet Sehgal. I have done my post graduation from AIMS, done my fellowship under the great Dr. Harsh Kumar sir, and I am right now the Unacademy educator in the Unacademy Learning app, also the head consultant glaucoma in Sharpsight Group of Eye Hospitals. So those residents who are basically attending this session, or those MBBS graduates also who are attending this session, how can you see my lectures? You can go to the Unacademy Learning app. You can install it on the iOS store or the Google Play Store. And if you are a NEET PG aspirant, you can basically subscribe for the FMG batch or for the next 2022 morning and the evening batch, where we have the plus subscription and the iconic subscription, where you would get the live classes as well as video classes, and you can use my code, that is OPHTHAL10, to basically get a 10% discount on whatever course that you want for the PGME. Okay, so I come back to my session today, that is the micropulse laser for management of glaucoma. So before I basically start this session, this is the compulsory voice and the video check. Am I audible to all of you? Okay, so micropulse laser for management of glaucoma. So the what was the conventional surgeries that we did for the glaucoma? That is our trabeculectomy surgeries. So if you can see in the trabeculectomy surgery, what we are doing is we are incising the conjunctiva, making a scleral flap, if you can see here. After making a scleral flap, we go inside the eye, put the air bubble, make a opening in the sclera, I call it ostium. After making the opening in the sclera, we basically remove the iris and then we close the flap. So this is basically a conventional trabeculectomy surgery. The problem with this conventional surgery was sometimes we ended up in hypotony, sometimes we ended up in a overhanging thin bleb, sometimes we had a fibrosis of the bleb, so it is not basically filtering. So even though a gold standard for last 20 or 25 years, still this surgery was having some doubts in the minds of the surgeons and a lot of doubt in the minds of the patient. And then we have a fearful phenomena which we call a wipeout phenomena. So what were the options that we had? So some new options came, like the micro-invasive glaucoma surgeries like Zen implant, trabeculotomy. But what we have seen is that even the micro-invasive glaucoma surgeries, they also had some invasive criteria. We had the selective laser trabeculoplasties, but these selective laser trabeculoplasties, they were not having so much of the IOP reduction that we would have thought about. Or basically, I can say that the SLTs or the ALTs, in my experience, I have done not many, but whatever I have done and I have seen from my colleagues, the IOP reduction was not as much as we thought about. And the second thing was that it was within few months, it the patient was in the same area where he was earlier. The next important point, which was against the laser trabeculoplasties, is that lot of patients, or I would say the majority of patients in India, they were of the angle closure variety, and to do a laser trabeculoplasty, you need to see the trabecular meshwork. So that was the problem and the lacuna in our management, which started from the medical management, and then we went to the lasers, and finally we went to the incisional surgeries. So with this, what we needed was something more. Okay, so the problem was that we were not having anything. Now if I get a technology, okay, more common, more relevant in this era of post COVID scenarios, that if I get a technology which can decrease the intraocular pressure, and second thing what it can do is that it can basically uh, decrease the number of medications, it would basically have less side effects or more chances of a rapid visual recovery. Would I like to have that in my armory? So very good. So definitely I would like to have something which is more safer for me, would be more safer for the patient, would be less time consuming, and very important nowadays, would have less amount of the follow up for the patients. Okay, so then we had this technology which is I call micro pulse laser. Okay, what I used was a diode laser. So you would be saying that, sir, diode laser was earlier also, we were doing a DLCPs, diode laser cyclophotocoagulation. So what is the difference between a DLCP and a micropulse laser? So in the micropulse laser, what we were having is that this micropulse laser, it is not a continuous cycle laser. It was on for 1/3 of the time and off for 2/3 of the time. So in pulses, okay, I just make a diagram. So in pulses, it was basically giving the laser. And these pulses, basically what they were doing is they are increasing the uveoscleral as well as trabecular meshwork outflow. So what I would be telling you is that ultrastructurally, through lot of studies, they have seen that the outflow mechanism is basically getting increased. And because it is in the short duration, okay, this is a micro pulse, it is in a short duration, so the chances of the destruction of the tissue, remember a DLCP or a cyclocryo basically works with the destruction. Okay, so destruction of your ciliary body, which may lead into the phthisis or atrophic bulbi, so that is very very minimal chances for that. Okay, so that's why I definitely preferred this micropulse laser. Okay, now you would ask me, sir, in which cases I can go with the micropulse laser? So any patient suffering from glaucoma, whether he is a pseudo exfoliation, pigment dispersion, primary angle closure, primary open angle glaucoma, if any patient is there on maximum medical therapy, okay, maximum medical therapy, you can say 2 bottles and 4 drugs. So you have, let's say a patient is on a PG analog inhibitor, sorry, a PG analog with a beta blocker, with a carbonic anhydrase inhibitor, and with a your rho kinase inhibitor. So if the patient is on maximum medical therapy, still the IOP is not reducing, you can definitely go for that. And even in those patients who feel that, sir, I want to get rid of this medication, I can go there also. If the patient is basically not very suitable for the filtration surgery, or if the patient want to avoid the filtration surgery, let's say he is having a zero point 0.9, a very a dangerous looking disc, and he says that, sir, I do not want to go for a filtration surgery. Do you have any option? So yes, you can go for that. Even if you want to go for a filtration surgery, let's say there is a 50 millimeter IOP, okay, and the complications of wipeout and other things are much more in a 50 millimeter IOP as compared to a 25 millimeter of IOP. So what you do is you do a micropulse laser, decrease the IOP from 50 to 30, and then at that point of time you can do it more safely, your shunt procedure or filtration procedure. Even in the secondary glaucomas, I had some very good results in my post vitreoretinal glaucoma, or even in post PK glaucomas. You can use this. Even there are few studies they have used it in the congenital glaucoma also. So see the importance and how much is the range of the patients which can be done this micropulse laser. Very easy to set up. This is the micropulse laser that we are having. This is the Iridex micropulse laser. So if you can see here, very easy. I started the machine. Okay, so after starting the machine, these lights are blinking. So then what I did was, see, there is a Cyclo G6 which is coming here. Cyclo G6 micropulse laser system. Okay, so now you can see this settings are coming. I just opened this and put the probe here. Okay, I then fixed it. Very easy to do setup. Okay, so as soon as I did the setup, it is coming 31.3 duty cycle. Okay, I am just showing you again. See, it is coming. I just let me do it again. So 31.3 duty cycle, if you can see here, and then there is a 50-second duration that is coming here. Okay, so everything is fine. I basically, now what I am doing is I am increasing the duration. The duration is fixed, so any resident or consultant who is basically seeing this session, so what is the protocol right now? I do it in 2000 millivolt and I do it in the 80-second duration. Okay, so 80 seconds superiorly and 80 second inferiorly I do this laser. Okay, so I just basically making it 80 seconds. Okay, so can you see here? Fair enough. And then this green light is blinking, so this means now everything is ready. Okay, so this is the setup of micropulse laser. Now what I do is I basically put the peribulbar anesthesia, or it can be done in with the topical anesthesia. Some people are doing it with the lignocaine jelly also, to decrease the amount of pain. And very important for your patient is the patient comfort. I usually do a peribulbar anesthesia, and whatever cases that I have done, I have not seen a lot of patients who complain with a pain in this procedure. Okay, unlike which is reported in the DLCPs and cyclocryo, that patient says that after this my lid swollen up was there and I had a lot of pain. Till now, till here, I am not having a patient who complained of pain after this. Very important is when you are doing it. So the procedure is that, let's say this is my superior hemisphere, this is my inferior hemisphere. So around the ciliary body, 1 millimeter to 2 millimeter of limbus, I put a probe here. Okay, so I put a probe here. I can go in the superior hemisphere. So this would be a painting type of motion. I would show you how the painting type of motion is there. Do not put too much of pressure on the probe, and it should be perpendicular to your surface. Okay, so I write it here. The probe should be perpendicular to the surface. We usually, as in our cyclo, cryo and DLCP, I avoid 3 o'clock and 9 o'clock positions here. Okay, I avoid that and I do a painting motion 1 to 2 millimeter from the limbus, and you can use a illuminator probe also. So if you have a VR setup, vitreoretinal setup, you can use a illuminator probe also to basically visualize the ciliary body. So those patients, like those who are the high myopics, where you and the patient both are afraid of the surgery, they have a thin sclera. So if you want to exactly see where is the ciliary body, you can use a illuminator probe to see it. Okay, So I do a painting motion of the superior quadrant. Okay, 80 second we do in the superior quadrant, and the similar motion, so I go from 3 o'clock to 9 o'clock, go back from 9 o'clock to 3 o'clock, then again 3 o'clock to 9 o'clock, 9 o'clock to 3 o'clock. Okay, and there is some timer which is going on. So in the machine there is an automatic timer, so tick 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 tick. Okay, so what it does is that from 3 o'clock to 9 o'clock, it basically, when it is done, there is a beep sound that comes. So similar you can do it in the inferior quadrant. If let's say there is a trabeculectomy there, if there is a trabeculectomy or a staphyloma is there, then you can also take a quadrant technique. So quadrant technique means that you do one quadrant, go back, then go again, then go back. Okay, this I call a quadrant technique. So similar, you can do it in one quadrant, followed by other quadrant, followed by the third quadrant, and followed by the fourth quadrant. Okay, so this is called quadrant technique. Whatever you feel comfortable, you can do. Whether you want to do a quadrant technique or whether you want to go for a hemisphere technique is totally your choice. Okay, so mark the 3 o'clock and 9 o'clock position at the limbus. Remember, very important thing is I would just show you the probe of the MP3 probe. Okay, so what I use is the MP3 probe. What is the meaning of MP3? Okay, so it is the pars plana probe. Okay, pars plana micropulse pars plana probe. So this is MP3 probe. So it has a notch. So it is like this. It has a notch. This is called notch, and this notch should always point towards the limbus. Okay, this notch should always point towards the limbus, and very important here is that always put viscoelastic gel. Okay, so this laser to pass through the conjunctiva and the sclera to the ciliary body, you need a medium. Okay, so over the conjunctiva you can use a HPMC gel and then do the laser. Okay, you must be having no air here there, but you use something which basically makes some media. You can use a HPMC gel or anything that you want, but there should be some viscoelastic material beneath the probe. Okay, and very important is do a painting motion. So painting motion का मतलब हुआ कि you do not press too much. Okay, and this probe, the position of this probe should be 90 degree to the limbus and the sclera. Okay, very important this. Okay, so just see here how the probe is seen. Can you see? This is the micropulse probe, this is the other edge, and this is the, if you can appreciate here, this is the notch, and this notch I am just making it more clear to you. So this notch which you are seeing, this notch should be towards the limbus. Okay, so this is the basically micro pulse probe or a MP3 probe. I told you, avoid the position of staphyloma or the conjunctival scarring, or if there is a trabeculectomy bleb there. Okay, and when you use, so I'm not talking about the other machine, I'm talking about the Iridex micropulse probe. So whenever you use it, this probe can be used for 90 minutes. Okay, so one single probe can be used in 5 to 6 cases. So sometimes they say that you can do a 10 cases, but what we have seen is that even in the studies that after 5 to 6 cases, the amount of energy that is basically given, or the amount of pulse laser which is given, that decreases. Anyways, won't go into the too much of the controversies, but still a single probe you can use it for 5 to 6 cases. But very important is, before you go to the other case, you have done one case and then you are going to the other case, please disinfect the probe with the alcohol swab. Okay, very important. Okay, post operative regimen, it is very much same like a cyclocryo or a DLCP. You use a antibiotic steroid combination 4 times a day, and after 1 week you can just taper it. You may see some cells or 1 or 2 plus cells in the first post operative day. Usually it goes by itself. I have not seen something which is a chronic uveitis, which is sometimes basically feared. in these cases. And you can with because this is something everyone's choice. If theoretically, if the patient is having some issues, or if you are basically a bit not convinced about the efficacy, you can basically use a hometropine there, because you may have some inflammation or some synechia or pigment dispersal. I would also use a NSAID, a topical NSAID like a Nepafinac. Very important is you continue all the AGMs. Okay, so any all the anti-glaucoma medications which you are using, you continue with them. Okay, very very important for that. So just see how we are doing it. So if you can see here, this is a patient who has got a previous trab here, and this is the notch. So this notch I am putting towards the limbus. Okay, so if you can see here, a micropulse procedure which is going on. Okay, so okay, I am just making a 3 o'clock and 9 o'clock position, and now if you can see this probe, I am doing a quadrant technique. Okay, sorry, this is the hemisphere technique. See, can you see it? So I am just moving it like a painting motion in the inferior hemisphere. Simple and very very effective. Okay, this is, I just show you again, mark the 3 o'clock and 9 o'clock position and did the inferior quadrant first. Okay, so very important here is, do not over mark, or if there is a subconjunctival hemorrhage, what we have seen is that these marks or hemorrhage, they can also cause the decrease in the laser penetrance. Okay, so whenever you are doing it, avoid, what this is what I have seen in my experience also, avoid using a tooth forceps. Okay, so why I avoid making a tooth forceps, because I do not want any hemorrhage in the conjunctiva. Okay, so let's move the another case. If you can see, where we are doing a corneal traction quadrant technique. Okay, so I have put a viscoelastic gel. See, I have put a viscoelastic gel, and then I am using a quadrant technique. Why I am using a quadrant technique? Because I am getting a bleb here. Okay, a staphylomatous trabeculectomy bleb here. I do not do a laser over there. I just do in the bare area. Okay, see, this is something. And also I would basically request you that whenever you are doing a diode laser, always wear the red glasses. Okay, so do not damage your own eye when you are doing it. Okay, so sometimes the Indians, they have a very deep seated eyes. Okay, these deep seated eyes, you do not have so much of space to do the lasers. So in that case, what I do is that I make a corneal traction suture. Okay, so I put a Vicryl suture in the cornea. Okay, see it. So I put a Vicryl suture in the cornea, and then with this, what I can do is, I can, like we do it in the trabeculectomy surgery, I can rotate the globe, and then with my assistant basically pulling the globe, I can do the laser in the quadrant that I want. Okay, so this is the corneal traction suture. A usual post-operative follow-up, I do it in the 1, 3 and 6 weeks, and basically how much is my response, I basically decrease the medication. Very important to you is, do not stop the medication at once. This laser basically is the effect usually comes in few weeks time. In two of my cases, I have done the repeated micropulse laser also. That is also an advantage. But this repeated micropulse laser, uh, my own experiences, I have not got very much exciting results. One patient I am still following up. But the thing is that see the response, and then you taper the medication accordingly. Okay, so my results, almost 25 to 30 eyes I have done. One patient I have not done myself, but I am following up that patient, where I had got a hypotonous maculopathy, and then we had a lamellar macular hole also. Otherwise, all of my patients, they are doing very good. 60 to 65 patients percent of my patients are having a good IOP control even after one and a half hour mean, 1.5 year mean follow up. which I say more than 5 millimeter decrease in the pressure or less than 21 millimeter of mercury is the pressure. Okay, so per se, what I have seen is that the patients where the no surgery is being done already and where I did it, they had much better results as compared to those patients in which the surgery has been done earlier. Okay, pain tolerance has been good except in one case, and that was also I am just following up that case, have not done it myself, uh, where the patient said that, sir, I had a lot of pain, but that patient was a diabetic patient also, and I think that the amount of the peribulbar block which was given was 5 ml, may be a bit insufficient, and the patient was not having a akinesia or a analgesia before the surgical procedure also. So plus minus, but till now I have not seen any major problem with the pain tolerance. Okay, so what is my advantages? Definitely my advantage is a very non-invasive procedure, less common dreaded complications. I have not gone to the OT again to any of my patient which I have done 25 eyes. I am just basically very happy with the post operative, I won't say outcomes because it is a small time, but I have not to go again for doing something again in this patients. Unfortunately, in trabeculectomy, out of every 10 cases that we do, 2 or 3 cases we are intervening again and again. So, Avinash, if the there is no bleb formed here, okay, this is just a something laser which is penetrating through the conjunctiva. So, the chances of blebitis is almost zero because there is no bleb there. Okay, then as a trabeculectomy surgery, it can be repeated also, and you are not injuring the conjunctiva. Very important point is, if you have done the surgery in this patient and you want to do it again, okay, or if you have done the laser once, you want to do it a trabeculectomy on the follow-up, you have not basically done harm to the conjunctiva. If you have done a shunt in the first go and then you want to go for a trabeculectomy, the amount of conjunctiva that you have basically damaged, that is more. So uh, definitely this is an advantage, and the patient has quicker rehabilitation. Within 2 hours you tell the patient to do anything that he wants, he can return back to his job. So very important in this COVID era scenario or post COVID era scenarios. Okay, and any patient who is having a systemic comorbidities, like the patient who is not fit for the surgery, I can do it here, there also. But lots of ifs and lots of buts is there in any of the procedure. So long term results we do not know. We per se, my own results, we have 1.5 to 2 years follow up. Results in Indian eyes, we have the first study by Dr. Murli Agra which has just come, and so far so good. Our sequential TSCPC, so means transscleral cyclophotocoagulation, which we are doing. So what were results in that? We still do not know much. We do not have more. We want to have more data, more multicentric data, and results in post-trabeculectomy shunt procedures. My own patients, there the results which I thought they were not as good, but let's see, the time would tell. And results in secondary glaucoma and congenital glaucoma, still they have to be seen. Okay, so this is all about the micropulse laser. Hope you would have seen this session. Any doubts you can just ask me. This procedure which I am doing it in the Sharpside group of eye hospitals, one of the leading eye chains in the India, with our centers all over the country. So basically, if anyone having wants a demo or wants to see the machine or anything, you can just come to me, and I would be very obliged to basically help you there. So from my side, it is done from today. Hope you would have enjoyed the session. Just give me a thumbs up if you would have liked this. And definitely, this is not too much of importance for the NEET PG, but I would just show you that how the things are changing, because every day, yes, we are doing the theoretical sessions, MCQs every day and now, but these technologies should always make you understand that uh, a lot of potential is there in every field, and see that every day we are doing so great things in the clinical setup. So be proud to be a doctor. Okay, be proud. to be a clinician. This is a phase which would go, and hope you would have liked the session. If you want more advancements in ophthalmology session, you can just click on the hit the bell icon for your notifications. And also I would request you to download the Unacademy learning app, the only learning app with a great platform where the educators all over the country are making you understand the knowledge. Okay, so ignite yourself, ignite your brains, and thank you very much for attending this session. It is good night from my side, and Jai Hind.